Oh, yes, so it's getting recorded.
Good morning, good afternoon, good evening, wherever you are in this world. We're so happy to be back again with our tumor section webinar series. We have a real treat for the group today. Dr. Giovanni Raffa will be speaking to us. I'll let Dr. Maria introduce him in a second. But I do want to thank the AANS for all their efforts helping the tumor section with these important webinars. We really think this educational initiative will benefit many. And please refer to the AANS YouTube and our new updated tumor section website. All our webinars are recorded. You can go back to them. They're quite educational and helpful. So at this point, I'd like to turn it over to Dr. Maria Noor, who will introduce Dr. Giovanni Raffa.
Thank you very much, sir. It's a pleasure and an honor to lead this wonderful webinar series with all those wonderful hosts that we do, all the wonderful speakers that we introduce each time. So it's a pleasure to introduce Dr. Giovanni Raffa, who is currently the chair of the ENS, the European Association of Neurosurgical Societies Young Neurosurgeons Committee, also the chair of the SINGE Society of United States Society of Neurosurgeons. He's also the chair of Young Neurosurgeon of the Society, Young Neurosurgeon Committee of the same society, and he's also an assistant professor at the Department of Neurosurgery at University of Messina in Italy. He's very, very active, and I think most of us, many of us who have got a lot of interest in reading research are very well aware of all his wonderful work. And recently, I'm so happy that he's sharing his wonderful talk today. And recently, I had this very wonderful coincidence of reading his editorial on the same and similar topics and in the Frontier. Then many of you might have already read this article. So thank you very much for your time today, and welcome to the webinar. And the floor is all yours now.
Thank you, Maria. It's a real pleasure and honor for me to be here today with you. I'm gonna share my screen. Can you see it now? Thank you for your kind introduction. And today we're gonna talk about preoperative brain mapping, and I would like also to give you some insight into neuromodulation for surgery of brain tumors located in eloquent areas. So you know better than me probably that intraoperative neurophysiological monitoring, mapping and monitoring, as well as awake surgery are the gold standard for surgical treatment of brain tumors located in eloquent areas. But we know that the functional organization of the brain is extremely complex. We have to map during surgery different and complex networks if we want to preserve them. And sometimes this can be time-consuming from surgeons, but also for patients, especially if we are working during awake surgery. So today, we can map these functional networks that we want to preserve during surgery just before entering the OR. That could help us in sparing time and be faster during our awake surgery, for example, and can help us to identify these functional networks and preserve them during surgery, thus improving the surgical outcome of our patients. So today we can talk about preoperative brain mapping using different technologies that merge electrophysiology, neuroimaging, and neuropsychology to identify these networks, analyze the relationship between the lesion and the functional networks that we want to preserve, and then we can use all this information to plan our surgical strategy and to achieve our maximal safe resection. So one of the most used technologies today is the navigated transcranial magnetic stimulation that allow us to perform our preoperative mapping using the same languages of our nervous system, so electrophysiology. And today, after about 10 years of papers written about the use of this kind of approach, for mapping functional network before surgery, we can say that nTMS is able, especially for some networks, for example, the motor networks, to anticipate the results of intraoperative mapping. So it can help us. It can help us in identify as well as we perform during surgery the motor cortex and to preserve the cortex during surgery. So we can achieve just operatively map of the relationship between the lesion and the motor cortex, as well as we can achieve it during surgery, even if the surgery is performed in a sleep fashion. So how it works? nTMS is based on the Faraday principle, and it allows for a focal manipulation of cortical activity thanks to the creation of a magnetic field that is created by a coil, that is this one that you can see in this picture. The magnetic field is applied, and the coil is applied over the scalp of our patient, who is comfortably seated on this chair. And this magnetic field is able to activate, to induce an electrical current through the scalp on the motor cortex, or in the cortical areas that are located just below the coil, and these allow us to manipulate the cortical activity. And in the end, these allow us to achieve a mapping of different cortical areas. So this is a video that shows how nTMS works. Of course, the difference between nTMS and standard TMS is that nTMS is combined with a neuronavigation system that allows us to upload our MRI scan images, provide a 3D reconstruction of the MRI scan, and then we can move the coil over the head of the patient and see exactly where we are performing our stimulation. This dipole is just the coil moving around the tumor and stimulating the cortex. We can use this kind of approach using two different stimulation patterns. We can use a single pulse stimulation pattern in which we want to activate the cortical areas below the coil, and this is the paradigm that we use for mapping the motor cortex, because when we induce cortical activation over the motor cortex, of course, we achieve a motor evoked potential, exactly as we achieve during intraoperative neurophysiological mapping. It's the same, but the patient is seated on our chair, and we can perform a very detailed mapping of the motor cortex. Because when we simulate over the M1, of course, we can achieve and register each single motor evoked potential. We can then even perform an offline analysis of our mapping, identifying the real spot, the real motor eloquent spot over the motor cortex. And this allows for the creation of this 3D reconstruction of the brain of our patient. And as you can see here, you can see different spots of different colors, because each single spot represents a different motor evoked potential and corresponds to different muscles that have been activated using the nTMS. So we can achieve a very detailed mapping of different muscles, starting from the tibialis anteriors, but including also the abductor pollicis brevis, the orbicularis oris, and so on. And therefore, we achieve very accurate mapping that allow us to identify the relationship between the lesion and the and the motor cortex. And this is very important if we want to plan our surgery, because as you can see in this slide, I want to show you two different cases, two lesions. If you look at the unaffected hemisphere, the left one, you can see the omega sign. So probably both lesions are anterior to the omega sign, but when we perform our mapping and our 3D reconstruction, you can see that the risk of these two different tumors is completely different, because of course in the first case the motor cortex is just in front of the lesion. It is far away from the lesion, so surgical resection can be safer in this case, while in the second case the lesion is just below the motor cortex. So of course the surgery will be more risky. This is another case. These two slices are coming from the same MRI scan from the same patient, just showing both, just to understand where the omega sign is. Probably is here. You can see the lesion in the affected hemisphere is probably anterior to the omega sign. We must define if the lesion involves or not the motor cortex. And again, we can perform our mapping. This is the final mapping of the motor cortex that is just in front of the lesion. The lesion is posterior, the motor posteriorly located to the motor cortex. So in this case, the risk for the development of postoperative motor deficits is intermediate, and is different as compared to this case. Again, we have here two different slices from the same patient. Probably the omega sign in the unaffected hemisphere is this one in red, and the lesion again is located anterior to the omega sign. And when we performed our mapping and our 3D reconstruction, you can see in this case the lesion is infiltrating the ventral portion of the motor cortex. So again, the risk for surgery in this case is higher as compared to the previous case. Of course, the nTMS mapping provides just a cortical representation of the motor cortex, of the motor Eloquent site, but we need also information about the subcortical brain matter tracts. And when we talk about motor networks, of course, we need information about the reconstruction of the cortical spinal tract. And the nTMS map, so the map achieved by nTMS stimulation, can be used as seating region for the DTI tractography of the cortical spinal tract. As you can see here, we can map different portion of the motor cortex corresponding to different motor vocal potential and therefore to different activated muscles. And you can use this region of interest for the reconstruction of a somatotopic corticospinal tract, in which different colors represent different fibers coming from different areas of the motor cortex, in which there is the representation of different muscles. So in green, you can see fibers coming from the leg area, in red, fibers coming from the arm area, while in pink, fibers coming from the face area. And we can have a somatotopic reconstruction of the corticospinal tract. And all this information can be then implemented in our neuronavigation system and can help us in guiding during surgery our intraoperative mapping, the visualization of the corticospinal tract of the motor cortex can help us during surgery, making our intraoperative mapping and even monitoring faster than in cases in which we have no other information. So that can help us in preserving the eloquent structures, both at a cortical level and subcortical level. And I want to show some cases demonstrating the importance of preoperative mapping and planning, in which we can visualize both motor cortex and corticospinal tract. This is a lesion that probably is located anterior to the motor cortex. But if you look at the MRI scan into the sagittal plane, you can see that the deeper portion of the lesion goes back and probably is in contact with the corticospinal tract. This is another case, a recurrent glioblastoma, probably involving the motor cortex and the corticospinal tract. Both cases can be considered at high risk for the development of postoperative motor deficits, so we need intraoperative brain mapping and monitoring. But when we perform the mapping, the nTMS mapping, the 3D reconstruction also of the corticospinal tract, and analyze the relationship between the lesion and the network, you can see that in the first case, the lesion is just dislocating the corticospinal tract, in particular the fibers coming from the leg area of the motor cortex, while in the second case on your right, you can see the lesion infiltrate the corticospinal tract. So we know before entering in the OR that the second case is at higher risk for development of postoperative motor deficit. So we must be more careful in mapping and monitoring the motor function during surgery of the second case, while in the first case, probably we can try to achieve even a gross total resection that in the second case probably is not possible if we want to preserve the motor function. So we can plan our surgical strategy thanks to all this information provided by the nTMS preoperative mapping. This is another case, a lesion with a huge perilesional edema, the omega sign in the unaffected hemisphere, in the left one is there. Probably the relanding sulcus fissure is located here posteriorly, but this is the nTMS mapping. We must understand before entering the UR if the lesion involves the motor cortex or is just a premotor lesion. And this is the planning. You can see that the lesion is located, of course, anteriorly to the corticospinal tract, but it goes close to the corticospinal tract, especially to the pink face fibers and the red one from the arm. And thanks to all this information, we can plan our surgical strategy trying to reach the lesion without inducing damage to the corticospinal tract. This is an example of the preoperative mapping with the trajectory that we want to use to breach a lesion without passing through the corticospinal tract or the motor cortex. And let's go to see how we manage some of these cases. This is the first case I show you. This is a gentleman with a right relandic glioblastoma. This is the 3D reconstruction. The patient has had a slight motor deficits on the hand, 3/5 at the MRC scale. This is the 3D reconstruction of the relationship between the motor cortex that here is represented by the white spots, which are the nTMS spot. And this is a preoperative reconstruction. You can see here the lesion, the white nTMS spot located over the lesion. There are some vascular structures that correspond exactly to what we found during surgery. You can see here this venous drainage, this small venous drainage. So we achieved a really accurate reconstruction just before entering in the OR. So we also analyzed the relationship with the corticospinal tract. This is the 3D reconstruction, the tumor, the green fibers from the leg, the red fibers coming from the arm and arm area of the motor cortex, and the pink fibers coming from the face representation. So we entered the OR knowing exactly what we want to do, where the location of the lesion is, and we were aware that the risk of postoperative deficits was really high. In this case, we performed our intraoperative mapping guided by our information implemented into the neuronavigation system. We found the lesion, started resecting the lesion using also the 5LA guidance, and of course using the guidance of the intraoperative neurophysiological mapping. So in the end, we used all those information to plan our surgical strategy and to perform faster mapping during surgery. This is the patient who had a transient motor deficits on the left arm after a few days from surgery, but then completely recovered after 1 month. This is the other case I showed you before. This is a female, 41 years old, with this right motor eloquent glioblastoma that was located in contact with the corticospinal tract, especially when we look at the deeper portion of the lesion. This is an example of the planning. And this is what we how we used all this information during surgery. In this case, we used fluorescein for lesion resection, and of course resection was performed using intraoperative guidance of intraoperative neurophysiology, and all the information provided by the nTMS were implemented into the neuronavigation system and helped us to easily find the relationship between the lesion and the corticospinal tract, and to preserve the corticospinal tract during resection. Resection was complete, as you can see here, and the patient did not experience any kind of postoperative neurological deficits. Let's go now talking about literature. What literature say about the efficacy of this kind of approach? Sorry, yeah. I want to show some papers that compared, for example, another important tool that we have to perform preoperative mapping of functional network, that is functional MRI, that is probably more diffuse than nTMS, because everyone has an MRI scan, can have also the software for performing functional MRI. But as you can see here in this paper published in 2020, that is a meta-analysis, the nTMS mapping resulted to have a higher spatial accuracy than functional MRI, as compared to the gold standard, that is the direct cortical stimulation. And this is another paper published in 2022 analyzing the importance of this kind of planning before surgery for stratification of patients according to the risk of developing postoperative motor deficits. So the 3D reconstruction of the motor network using nTMS cortical mapping plus nTMS-based DTI tractography can help us in stratified patients. So all patients in which there is the tumor to tract distance equal or less than 8 millimeters should be considered at high risk for new permanent postoperative motor deficits. And such an information can be used by surgeon to be aware about the risk, but can be used also to talk with patient when we have to explain the risk of surgery. So this is quite important, in my opinion, to know exactly the risk before entering in the operating room. And this is another study, a meta-analysis I conducted in 2019, analyzing all studies that were published until that time, using the nTMS preoperative mapping for surgery of motor eloquent lesion. There were a total of 8 studies at that time, but all studies agreed in the fact that the nTMS motor mapping slightly reduced the occurrence of new postoperative permanent motor deficits as compared to standard surgery using, of course, intraoperative mapping and monitoring. So if we add preoperative mapping by nTMS, we can reduce the occurrence of postoperative motor deficits. And again, when we analyze the extent of resection, the nTMS motor mapping resulted to significantly increase the gross total resection rate. And this is probably due to the fact that the use of this kind of mapping and planning increases the awareness of surgeon about the relationship between the lesion and the entire motor network. At this point, we can move to the second pattern that we can use for mapping of eloquent cortex. This kind of pattern of paradigm is based on the use of repetitive stimulation during the execution of a task. In this case, the repetitive stimulation aims to interfere with the cortical activity during the execution of the task. So this kind of stimulation creates a transient lesions into eloquent cortical areas, so the patient cannot perform a standard task that depends on, that we can choose according to the function that we want to study. For example, this kind of pattern is used for the identification of cortical language eloquent spots. So in these cases, we ask the patient to perform a standard object naming task, as well as we usually perform during awake surgery, and then we apply our repetitive stimulation, trying to interfere with the cortical areas involved in the language network. So if the patient has or shows a speech arrest or some speech error, that means that the spot that we are stimulating in that specific time is involved in the language network. So we can map the cortical language language network. This is a video of how it works. I apologize for this in Italian, but if you can see, as we perform during awake surgery, we ask the patient to name some objects, and then we can try to interfere with the activity of her language network. The difference is that here we are not in the OR. The patient is relaxed, is seated in a comfortable chair, so we can map the cortical areas involved in the network language in an easy way without the stress of the awake surgery. This is the final map that we can achieve when we perform our nTMS language mapping. Different spots correspond to different language error, but again, we can understand before entering the OR the relationship between the lesion and the cortical language eloquent site. What about the accuracy of this kind of approach? Conversely, then the model mapping that is really accurate. When we talk about nTMS language mapping, we find in the literature different results. So the interpretation of evidence from literature is not so straightforward. I want to show you this systematic review that is the same that I showed you before. If you can see, value reported in different studies range from 10 to 100%, but I want to highlight especially this kind of result, the negative predictive value of the technique that ranges from 57 to 100% in different studies analyzed by this systematic review. This is another study published by the colleagues from the MD Anderson Cancer Center that compared the accuracy of nTMS versus functional MRI in comparison both to the gold standard direct cortical stimulation. If you look at the two box, the nTMS seems to be more accurate than functional MRI. But again, if we look here, you can see a very high negative predictive value that is in this specific case 99%. Another paper published by my friends from the Charité Neurosurgery department in Berlin, Germany, that data regarding sensitivity and specificity were quite different, but again, a very high negative predictive value was reported. In this case, it was 96%. Collectively, all these data suggests that the nTMS is very accurate in detecting negative cortical sites. So if we perform our nTMS stimulation and the cortical areas that are stimulated are not identified as eloquent, but they are just not eloquent, we can resect those areas because the negative predictive value of these techniques is very high. And this concept is not so different from what was introduced by Dr. Berger and Sanai more than 10 years ago when they introduced the concept of negative mapping during awake surgery. So if a cortical area is not eloquent for language during intraoperative, but also during preoperative mapping using nTMS, that area can be safely resected. So if we rely on negative mapping during intraoperative mapping during awake surgery, we can rely also on negative mapping achieved by nTMS because the negative predictive value is very, very high. The accuracy in detecting positive language areas instead is not so high. So at this moment, I would say that we can rely also only on the ability of this kind of preoperative mapping in detective, not language eloquent areas. Of course, even for lesion located close to the language network, we must achieve a reconstruction of the subcortical white matter tracts involved into the language network. This is not so easy. Of course, the language network is much more complex than the motor network, but again, we can use the nTMS spots achieved by nTMS stimulation over the cortex of our patients to perform a DTI reconstruction of the different fascicles involved in the language network. And again, we can analyze before entering the OR the spatial relationship between the lesion and the tumor, and this information can be used to stratify our patients, because if we observe a lesion to tract distance equal or less than 6 16 millimeters for the arcuate fascicle, or equal or less to 25 millimeters in case of other fascicles, for example, the inferior front occipital fascicles or the inferior longitudinal fascicle, the risk of developing postoperative language deficits is very high. What is the impact of this kind of approach using nTMS language mapping and reconstruction of the language network before entering the UR into the clinical practice? This is a paper that I published a few years ago, in which we analyzed the accuracy of the nTMS mapping, and again, for language, negative predictive value is very, very high. And we analyze also the ability of the nTMS mapping to predict the occurrence of postoperative language deficits. And again, we observed that this kind of approach is able to reliably predict the occurrence of postoperative aphasia. And then we can use this kind of approach even for mapping other areas involved in different complex cognitive functions. Of course, in these cases, the mapping is not easy, but we try to implement some neuropsychological tests for the evaluation of other functions, like, for example, visuospatial abilities, trying to map these areas at the cortical level and trying to preserve these areas to avoid postoperative neglect. This kind of mapping can be combined with the D3I reconstruction even of the subcortical white matter tracts, in particular, in this case, the reconstruction of the superior longitudinal fascicle that is involved in the visuospatial network. And again, all this information can be used to plan our surgical strategies, try to preserve not only motor cortex, not only the language network if we are in the dominant hemisphere, but also, for example, the visuospatial network. And we performed a very small study in which we observed that this kind of approach is able to improve the postoperative visuospatial outcome of our patient. So in the end, after this description of the techniques, I want to highlight the importance of this kind of approach and how we can use this kind of approach during our daily practice. So, as I said many times, the most important application of this kind of preoperative mapping and planning is, of course, to plan the best surgical strategy to achieve our maximal safe resection. Then we can use all this information to stratify patients according to the risk of developing postoperative motor or language deficits. And lastly, we have to use all this information during surgery implemented in our neuronavigation system to make our intraoperative mapping faster. This kind of approach is not replacing the intraoperative mapping and monitoring, which is still the gold standard, but the aim of this kind of approach is to enter into the UR with clear ideas about the relationship between the lesion and the surrounding function networks, and to use all this information to make our intraoperative mapping easier and faster, especially if we are dealing with patients with language eloquent lesions. So if we are planning an awake surgery, so this can help us in make awake surgery a more comfortable experience both for the surgeon and for our patient. So every time in my institution we deal with patients with suspected eloquent lesion, we performed our nTMS mapping, trying to analyze the relationship between the motor network, the language network, or the visuospatial network with the tumor. And in case this kind, in the case this kind of preoperative mapping and planning discloses a close relationship, so the lesion is considered is considered highly eloquent for the motor, language, or visuospatial abilities, we decide according to this information if we want to perform a WEG surgery or not. And then in case, for example, in case with motor eloquent lesion, usually we perform a sleep surgery. In case with language eloquent lesions, we usually perform a WEG surgery, but in some cases in which the patient is not eligible to undergo a WEG surgery, we can use all this information to guide our resection. This is our series, more than 500 lesions treated using this kind of approach, including high-grade gliomas, low-grade gliomas, metastasis, but also some vascular lesion. I want to show some cases again. This is a lesion that probably is located close to the Rolandic fissure. The 3D mapping showed that the lesion was completely posterior to the motor cortex. Also, the 3D planning showed the relationship between the corticospinal tract and the lesion that was located posterior to the corticospinal tract. And this is what we performed. So surgery guided by intraoperative mapping and monitoring. We use information coming from the neuronavigation, our planning, implemented into the neuronavigation to locate the motor cortex faster. And then we, of course, started with our resection, standard microsurgical resection. This is the postoperative MRI scan. This is another case with left temporal glioblastoma. This is the case I showed you before. The nTMS spots are surrounding the lesion. This is the relationship between each single language fascicle and the lesion. And this is what we perform, the WEG surgery under the guidance of our information. We look at the lesion, identify the relationship between the lesion and the cortical subcortical eloquent structures, and perform our surgery, making the experience for the patient more comfortable. This is the postoperative language deficit, the postoperative MRI scan with the complete resection of the lesion, and the patient didn't experience any kind of neurologic of language deficit. But there are also some cases in which, as I told you before, a WEG surgery is not feasible, for example, in children or older patients that are not able to cooperate during a WEG surgery, or patient with psychiatric disorders. In Italy, this happens very often. So in all these cases, when a WEG surgery is not feasible, we cannot perform standard surgery as we performed 20 years ago without any kind of functional information. We can use all this information provided by the nTMS preoperative mapping to perform our resection. Even if we are not able to perform our WEG surgery. So this is particularly important in children that can be submitted to nTMS mapping easily. This is a case of a lesion located close to the temporoparieto-occipital junction. The patient was not eligible for a WEG surgery because he was not cooperating. He was not eligible for a WEG surgery, as I told you before. The lesion is close to the vertical segment of the arcuate fascicle here. So we were aware that we must be careful when dealing with the deeper portion of the lesion because it was close to the arcuate fascicle. So this is what we have done, sleep surgery under the guidance of this information. And this is the preoperative MRI scan showing the close relationship between the vertical segment of the arcuate fascicle and the lesion. And this is the postoperative MRI scan in which you can see that the vertical segment of the arcuate fascicle was completely preserved and the patient did not experience any language deficits. This is another case with a left temporal pole glioblastoma. Even in this case, wax surgery was not feasible. This is the 3D reconstruction of the relationship between the lesion and the cortical and subcortical eloquent structures, but the patient after surgery, that was a sleep surgery, because as I told you, the patient was not eligible to undergo a wax surgery, we observed anomia. This is because when we perform the postoperative MRI scan, you can see here, we include in our resection a part of the uncinate fascicle. So I want to show you this case because it's true that nTMS mapping can be used during surgery, but we must not forget a brain shift. So in all those cases in which wax surgery is not feasible, this kind of information can help us, but we must bear in mind that the brain shift is a high risk that can induce even resection of eloquent structure. So nTMS mapping and planning can be useful in patients who are not eligible for wax surgery, but brain shift is an important issue that we must consider. And we decided to analyze our series, including all those patients who were not eligible to undergo wax surgery. And all these patients were operated using just information provided by the nTMS planning. We analyzed the extent of resection and the occurrence of new permanent language deficits. Go directly to the conclusion. So the occurrence of postoperative permanent language deficits was 7.3%. But if we look at the results after stratification of patients in true eloquent lesions, so lesions that were disclosed to be really close to the network using our nTMS preoperative mapping and planning, and those considered false eloquent because the nTMS planning disclosed a safe distance between the tumor and the lesion, you can see that in the end, we observed a new permanent postoperative language deficit only in one patient out of 61. Regarding the extent of resection, we achieved gross total resection in 80% of cases. And again, it was 100% of cases when we operated on patients who were stratified as false eloquent according to the nTMS preoperative. Lastly, I want to show another possible application or combination of the nTMS preoperative mapping and planning with the use of tubular retractors for deep-seated lesion. All these lesions, intraventricular lesion or deeply located lesion, can be reached using a tubular retractor, and these tubular retractors can be inserted through the brain parenchyma using the nTMS preoperative mapping and planning as a guide for reaching the lesion, trying to preserve the network, the functional networks located close to the lesion. So we can use this kind of planning like minefield in which we want to reach our lesion, preserving the eloquent networks. I want to show only a few cases. Like in this deep lesion located on the mesial portion of the temporal-occipital junction, close to the corpus callosum. This is the preoperative planning with the trajectory of the tubular retractor to reach the lesion. And this is what we have performed. We identified the sulcus, we opened the sulcus, we inserted our tubular retractor under the guidance of the neuronavigation, and then we reached the lesion, deep-seated lesion, and resected it under the 5LA guidance. This is the post-op MRI scan. This is another case of a huge, giant meningioma of the left trigone. This is the preoperative planning. I want to show you better. The lesion is very huge. These in green are the optic radiation. The orange fibers represent the arcuate fasciculus, and then we have also the other language fascicles that we want to preserve while resecting our lesion. So we decided to approach the lesion using this window between the arcuate fascicle in orange and the optical radiation in green. And we performed our resection with the same approach using a transsulcus insertion of the tubular retractor using the navigation guidance, and in the end we resected the lesion. But what I want to show is the postoperative reconstruction of the subcortical white matter tracts. You can see here the window below the arcuate fascicle. You can see also some fibers of the optic radiation that were displaced along the trajectory of the tubular retractor, and the patient did not experience any worsening of the visual abilities. And finally, I want to talk just a few minutes about the possibility to use the nTMS for neuromodulation. Neuromodulation is an old idea to try to induce neuroplasticity and move eloquent areas far away from the tumor. This is a paper published by Spanish colleagues, Garcia et al., were the authors, in which they performed the first resection on an eloquent glioma, language eloquent glioma. During this first resection, they found some eloquent sites that were preserved. Then they decided to apply a subdural grid to perform a continuous stimulation for 2 or 3 weeks, trying to interfere with the cortical organization of the language areas, and then they reoperate patients. These are the results on 5 cases. If you look at the red dots during the first surgery, which are the language eloquent cortical areas, after 1 or 2 weeks of stimulation using the subdural grids, most of these red dots became yellow, so became not eloquent for language anymore. So they were able, during the second surgery, to resect all these areas. This was very important to increase the extent of resection. But of course, if we talk about subdural grids, there are also a lot of complications, including infection or seizure in these patients. So the idea is to try to find a way to induce this kind of neuroplasticity using a non-invasive brain stimulation. Even you Dufault supported this idea, especially to facilitate reoperation in low-grade gliomas after a period in which we apply non-invasive stimulation, for example, nTMS stimulation. Some studies applied direct transcranial stimulation, that is another kind of non-invasive stimulation, in which it's applied a direct current over the scalp. We are starting now, after demonstrating that the nTMS repetitive stimulation is feasible and without risk, we start now a new approach based on nTMS stimulation, trying to simulate neuroplasticity in tumor with in patients with tumor located close to the motor network, using 2 different patterns. The first one is a stimulation, a repetitive stimulation for 14 days, once a day, and we are comparing this kind of approach with a stimulation lasting 7 days, twice with twice a day stimulation. We are working on that. We received support by the European Union to analyze if this kind of simulation can allow us to make surgery of motor eloquent tumors safer. We have, I can report to you some preliminary results in some patients in which we observed an increased seed-based and global connectivity after our stimulation. We observed also a significantly increased interhemispheric connectivity after our stimulation and increased connectivity between the M1 and the supplementary motor areas. We are now evaluating the impact of the extent on the extent of resection and surgical and neurological outcome, but I'm not ready to show you the result. I want to show just a case that we operated last week with a lesion involving the ventral portion of the motor cortex and probably also the Broca area, the opercularis area. This is the relationship between the arcuate fascicle, the nTMS spots that show a close relationship between the lesion and the motor and language network. This is a postoperative CT scan because patient is still waiting for performing our MRI scan. So I hope next webinar to show you the results even of this kind of approach based on nTMS-based neuromodulation. And I want to conclude, say thank you again to everybody. I think that today we are moving into an era in which preoperative mapping is reality and can help surgeons to improve the resection of motor and language eloquent brain tumors. Thank you so much.
Excellent lecture, Dr. Raffa. Thank you very much. I think we all learned so much. TMS is such a rapidly growing field right now, not only in some of the work you showed, but also in injury recovery post-surgery. I mean, you talked about some of the plasticity approaches that you're now applying. I had one question. I assume, based on what you showed, some of the data you showed were comparison studies between DCS versus navigated TMS, but I assume in most instances you are performing subcortical mapping with your TMS approach. Can you just tell us kind of what your routine is in those types of cases? You're using the navigated TMS with your tractography, but then during surgery, you're also doing subcortical mapping as well, right?
Yeah, for sure. Intraoperative mapping is still the gold standard. Intraoperative monitoring is still the gold standard. So I show you a case in which we place our grid for continuous monitoring of the motor cortex. And then when we deal with the deeper portion of the lesion, when we know that we are close to the corticospinal tract, according to the information provided by our preoperative planning, we start our subcortical mapping. Thanks to the info provided by our planning, we know when we are close, so we can increase the density of our subcortical mapping during surgery, trying to preserve in the best way the corticospinal tract or the language fascicles, because we are aware that we are closer to them.
One other question I had, and then I'm sure Maria has some questions. Who's doing your preoperative navigated TMS data collection? Is that the neuropsychologist? Like what member of your team collects that data?
Okay, this is different in different centers.
Yeah.
Because in some centers, neurophysiological technicians are in charge for the preoperative mapping. In my center, I prefer me and my young colleagues to perform the preoperative mapping because this really increases our awareness about the relationship between the eloquent cortical areas and the lesion. So I study on the case for 2 days, 3 days, because after nTMS mapping, of course, I perform also my reconstruction of the subcortical tract. So I enter in the OR with a very clear idea of what I want to do.
How long does it take you to do that when you do it yourself? And I love that. That makes complete sense to me.
I mean, a standard model mapping lasts about 20 minutes, no more than 20 minutes. And if you are skilled enough for DTI tractography, another 20 minutes will be enough if you are dealing with the model network. A little bit more if you want to reconstruct all different language fascicles, so about half an hour. But collectivity, no more than 1 hour. Is enough for this kind of preoperative mapping and planning.
Maria, would you like to?
Thank you. Yes, so thank you very much for this wonderful and very insightful talk. It was very enlightening. I think everyone enjoyed it very much. So there's one question that's in my mind, sir. With neuromodulation, have you, studied the effect of neuromodulation on the brain tumors themselves? Because when we say about neuromodulation and when we talk about neuroplasticity, well, it is a very oversimplified form that I say that they have effects on NMDA through the NMD receptors, which also have some role in tumor proliferations and growth in mitosis. So do you think that there is any effect of this neuromodulation on the tumors themselves, like especially in case of high-grade tumors?
No, I'm not aware about that. We are not at this stage. There are other technologies using different kind of stimulation, radio frequency to interfere with the tumor growth, but not nTMS. There are no, to my knowledge, there are no studies about that. This is nTMS can be used just to stimulate neuroplasticity around the lesion, not to have any effect on the tumor itself.
Thank you very much. So there are various interesting studies on all of these topics, and I think it's a very very growing topic, and it's so good. So thank you very much, sir, for your very insightful lecture and for your time.
We have one question from the audience. What is the efficiency accuracy of TMS for negative motor areas, SMA, premotor areas, etc.?
The negative for motor network, the accuracy is very high.
Yeah,
it's very high, absolutely. The motor network is the easy to be studied because you have just your coil, some surface electrodes on muscles. So if you are over the motor cortex, you will achieve you will register a motor evoked potential. But when we are moving a little bit away from the motor cortex, you will not record any more motor evoked potential. So for motor network, the accuracy is similar to that of intraoperative mapping.
wonderful. Well, I think we ran out of time. This is so great to hear from a leading expert in TMS. I think this is something we all need to consider in our practice for Eloquent located tumors during surgery. Once again, this is recorded. It's going to be on the tumor section website. Dr. Maria Noor has done a great job organizing this webinar. Thank you very much. Giovanni, have a nice day.
Thank you again. It was a privilege for me. Have a nice day.
Okay, take care.
Thank you very much. Thank
Bye.
you very much, sir.
Bye.